Dr. Mayank. He is a young retina specialist practicing in Delhi. Dr. Mayank. ये तो बहुत young है यार. Mayank, please.
So, thank you, sir. And please feel free to ask any questions throughout the talk. I'll be talking on OCT angiography, and briefly speaking, it's a non-invasive way of visualizing both the retinal as well as choroidal vasculature, and it typically is used as in an on-fast way, as against a typical OCT where we do a cross-sectional imaging. The brief principle of OCT angio is that by imaging the difference between several successive images, it's possible to visualize only motion. So here we've just used a picture of how, for example, a waterfall like this, a fountain, for example, can be visualized if you take multiple pictures of the same area, and then you can see what's static and what is not so static. And therefore, when you're using OCT angiography, a scan speed which is on a higher, like 80,000 A scans per second or so, is typically more useful. So utilizing the same principles, so this is how you would visualize all the retinal or choroidal vasculature. It does not become as relevant when you see it in the cross section, so therefore it's utilized more in an on-fast form. So when we're visualizing the on-fast image of using OCT angio, there are various layers that you can segment the OCT in. So typically it can be either a superficial layer or a deeper retinal layer, or the outer retina or the choriocapillaris that can be visualized. And when it comes to the choroidal layers, the choriocapillaris, Sattler's layer and Haller's layer all can be visualized as you segment the OCT scan, and typically most machines would give you that option to make that segmentation. So while it has an obvious advantage of being non-invasive and you can visualize at different depths, the limitation remains that you can't really see leakages as against fluorescein angiography, and very often fast flows appear as large black structures. So, and that's where, of course, the role of traditional fluorescein angiography comes in. Another limitation often is artifacts that can come when you're doing an OCT angio. And one of the most prominent ones is a motion artifact. So for example, if a patient was to blink the eyes, at that point, the scan will show a white line and there's nothing captured over there. So there are various ways of overcoming it, and a motion artifact, motion correction removal algorithm helps in that, an algorithm which takes 1 to 5 sequential exams and then combines all of them. Or you can have a more faster scan with a more scan speed, and of course use eye tracking to compensate for any patient's eye movements. These are examples of how you could use motion correction algorithms using multiple scans, 1, 2, 3, and then the final result over here where you've negated for all these areas where the white lines are appearing. The other artifact which is common is a projection artifact. So that's essentially the superficial vessels, which will not allow you so much of a visualization of the deeper vessels. It's most relevant actually in OCT angio when we're seeing the major retinal vessels, and that does not allow you to examine the lower, the deeper vessels. And for obvious reason, that the light is not passing through those. So again, projection artifact removal can be done by using the algorithms. And the scan now has been, to begin with, was just 3 by 3 millimeters, then 6 by 6, and now it's advanced to being available for 9 by 9 millimeters. So coming to actual clinical applications now, this is a study we did in 2015, which was right at the beginning when it was launched, and we found the most useful application of OCT angio for patients with type 1 CNVM. And that's where we saw two major patterns of neovascular membrane. One was what we call as a C-fan pattern, where there's a large vessel with a more of a C-fan appearance on the sides, typically seen like in a multi-layered PD. And the other pattern we saw was called a Medusa head pattern, and with the central large feeder vessel and large branching vascular networks on the side. And where OCT angio perhaps helped us was to understand that while there was fluid prior to any kind of an anti-VEGF in a naive eye, as the anti-VEGF was given, the branching vascular network decreased on the sides, the fluid resolved, but a central feeder vessel would always persist. And that's something which helped us perhaps understand the pathology, that the reason for the recurrences despite giving an anti-VEGF. Similar patterns in type 2 CNVM as well, and MACTEL as well, we're able to see these branching vascular networks. So again, a good example of how, while there is very minimal fluid or a very flat looking macula, but then again you can pick up how there can be a potential CNVM membrane underlying using OCT angio. For diabetic patients, it comes in use for seeing how there's a foveal avascular zone enlargement, and also seeing where there are potentially areas of neovascularization. So yes, so over here, for example, there is areas of absolute ischemia that are visualized on OCT angio. Moving to BRVO again, it's able to show us areas of ischemia as well as neovascularization. But of course, you wouldn't be able to pick up any leaks using the OCT angio, but definitely able to prognosticate given how much of a avascular or ischemic retina there is. Another example of PDR where you can see the neovascularization and areas of ischemia. CRVO would show us, again, areas of ischemia as well as neovascularization, perhaps very similar to what we're seeing in the PDR patients. And coming to OCT angio and its role in neurodegenerative conditions. So these would include Alzheimer's, multiple sclerosis, Parkinson's, but broadly speaking, that retinal microcirculation often mirrors these cerebral small vessel characteristics. And therefore, one of the most commoner things that's been studied, more of a research rule, you could say, is seeing the reduced microvascular density in patients with neurodegenerative conditions. So here's an example of a patient with Alzheimer's disease. And what's very evident here is perhaps the superficial capillary plexus being much lesser in density as compared to a normal control. And very similarly, in a patient with multiple sclerosis, you could see that a patient with multiple sclerosis with optic neuritis has a much lesser vascular density as well as compared to a healthy control individual. So yeah, that summarizes the talk. I'd be happy to take any questions now.
Any questions you have? Yes, please.
Wonderful presentation. So yes, with the ease that you can acquire in OCTA, so we don't hesitate, any unexplained visual loss, we subject a patient to an OCTA and look at the different slabs to pick up any pathology. So you pointed out that sometimes there's practically no retinal fluid, but you can see a big BVN or a classical CNVM underlying. So would you treat this patient, and how would you project the further follow-ups, and does that predict that you should treat such a patient when you find an underlying acquired CNVM?
Yes.
Some suboptimal vision?
Yeah, so for example, if you've given an anti-VEGF, I'm just citing an example, and you take an OCT angio after about a week's time, so the CNVM membrane, the one with feeder vessel without any fluid, will still persist, but there wouldn't be any fluid. So to cut the story short, yeah, you wouldn't treat the patient at that stage.
If it's the other eye and it has suboptimal vision?
Without a fluid, but CNVM membrane, yeah, again, so since there's no fluid, it wouldn't, it's not leaking and it's not causing an edema, so wouldn't warrant, in my opinion, a treatment. It might differ for myopic CNVMs though, where we don't tend to see as much of a fluid, but a CNVM which is there. So especially if there's a recent vision loss, and that's where the clinical context of it comes into play, that if there's a recent visual distortion or a black spot scotoma that's there, and there's not a fluid, but you're seeing a CNVM or a membrane which is evident either on OCT angio or a traditional angiography, then you would perhaps want to treat that.
Thank you.
Dr. Charu, you want to say something about this?
Yeah, so I feel here one point is made very particularly and very vividly, that it's always very, very important to look at the other eye, whether it be the OCT biomarkers, be it the OCT angio. When we see the pathology in one eye, to see the other eye, what is happening, a telltale sign or a precursor of disease is very, very important, and that really saves and modulates our treatment also.
Dr. Mine, what do you?
No, I think the only thing I'll say that yes, I agree with Mayank, we won't treat these cases, but when you're keeping them on a treat and extend protocol, we'll be more careful and we can educate them better about that the chances of recurrence are a bit higher, which we educate in every patient, but here we can emphasize it again by showing that you have to be on a more regular checkup. So that's what I'll say.
Any other questions we have? Thank you so much.